And I see that so far we have no questions. However, I have one question for both of you. First, I'll start with Dr. Urmi. Dr. Urmi, my question to you is, what are the challenges in standardizing MRD as a biomarker across centers in your experience?
So the challenges are multi-layered. Because the disease itself is heterogenic. There are methodological variability. There is a lack of universal marker. We also see a lot of immunophenotypic shifts in AML. So that makes it difficult to identify pre and post markers. Then sample handling, processing, and the cutoff value. Some centers use it as 0.01, some centers use it at 0.1. So yes, there are a lot of, having said that, that MRD is important, but there are still certain challenges. Again, not all centers do everything. So samples have to be outsourced. Then depending on what sample are you using a bone marrow, are you using peripheral blood? Then there are operator and instrument dependent variabilities, things like that. But a lot of us are doing it. A lot of us are using it. I'm sure Sukriti must have done a lot of those in ACTRACT, because ACTRACT is the hub for all of these things. So maybe Sukriti can throw some more light on the challenges that they faced while setting up the whole MRD in AML sort of a endeavor. Yeah.
So yes, I just want to know what is the question was, what were
challenges in standardization of MRD as a biomarker across centers?
So I'm currently in a Newburgh cycle path lab. So we are like being standardized in DMRD, we are standardizing AML MRD and multiple myeloma MRD. But yes, of course, the difficulties are there. We face a lot of difficulties in the sense that the sample only what we receive from various centers are sometimes dilute. Okay, sometimes the clinician fails to aspirate the right amount of quantity which we should get, and ultimately the events which we are acquiring in the millions, we just end up acquiring them in the lakhs. So it becomes very difficult. So it is basically patient to patient, okay, the problems we face, the challenges we face. And yes, the for example, for BMRD, it has been standardized that we have proper LOD, LOQ, that limit of detection and limit of quantification for particular sample. And it has been like all over India. I believe that it has been standardized in the view that 50 events should be limit of your detection and 20 events should be your limit of quantification. Below that, we are not even sure whether these are true positive events or whether they are suspicious events. Okay, so we should be standardizing those. And in the coming months, in August, we are holding a BMRD standardization small conference with the collaborating with Tata only. And if anyone has any query or something like that, they can come and they can send the technician staff from their side and can see that how do we standardize it and how the sample is being processed, because there are centers which are processing in a bulk lyse method, and some other centers which are just doing stain lyse wash method. That also hampers the end point of the MRDs. So it's again, yes, center to center as well as patient to patient. The challenges are there, but we are pulling out of it and standardizing and giving good MRDs report, and clinicians are happy with that.
All right, one more question I have got. So you mentioned about flow cytometry, NGS, as well as
PCR.
PCR. Yeah. So PCR, I wanted to come to PCR. What is the role of PCR in leukemias?
So
Acute leukemia.
in PCR, we have BCR ABL1 positive DLLs, right? Even PH positive CMLs we have, and PML, RARA, AMLs we have. We had then RANX1, T1 AMLs we have. So these are basically being picked up on PCR because in flow they will come positive, but they might not come positive. But if we do PCR, especially for BCR ABL1, the transcript for like depending P210, if it is for CML cases, and if it is 190 for BLL cases, the small quantity will not be picked by flow. It will be only picked up for PCR only. So for BCR ABL1, for PML RARA, and for even RANIX1 T1, these three are the important and which I remember right now. Maybe Dr. Urmi can help with it, but all.
Yeah, pretty much the same as what you mentioned. BCR ABL1 we do, PML RARA we do CML at the time of diagnosis we do a FISH, we don't do a PCRs, just so that there are any other translocations that can be picked up. And then once we know the transcript, then we just keep doing the quantitative PCR as monitoring assessment. PML RARA also pretty much the same thing. And yes, AML, in AML, we are utilizing PCRs, like you said, for core binding factor and RANX1 and NPN1 parameters for MRD monitoring. And the specific time points at which we do it is, yes, we do it at the end of induction, at the end of consolidation. And in transplants, we do it at first time point is at day plus 30, following which we do it every 3 monthly for the minimum of first 2 years. And the MRD, which we do at day plus 30, will tell us the chances of the disease being in remission, long-lasting, durable remission. So these are the timestamps as decided by ELN after, large cohort of studies and things like that.
Right, thank you. And one last question I have to both of you. Is there any role still for histochemical stains like MPO, SBB, or are they out of fashion?
No, absolutely. We still do MPOs. Our lab still does MPO. Sometimes MPO is the first one, quickest one to be done, and then at least we can differentiate between myeloid versus lymphoid. Very basic, very primitive way of doing it, but at least we get to know and quickly we can also get to know, based on the morphology and if there is a dense uptake about APML, things like that. So yeah, our pathologists are still fond of doing it for sure. So are we.
Dr. Sukriti, what's your take?
If we are doing MPO, we are still doing NSE, and these are the old standards, old methods, but these are the gold standards, I would say. And as ma'am said, yes, it's a very quick to differentiate between from lymphoid and myeloid. And you would be surprised to know that in CML, okay, which is a basically stem cell original neoplasm, in those the blasts are the normal myeloid blasts are MPO negative. Okay, so what we can do is for giving the accurate blast percentage, what we do is we run or we stain a slide with MPO, and in the since there are many myelocytes, so it will be more black. So every black is my myeloid precursors, and the stains with the cells which have not taken this stains with will be my lymphocytes, will be my blast and erythroid precursors, right? So I can appreciate erythroid precursor, I can appreciate lymphocyte, but the big cells or medium to large size cells which have not taken MPO are my blast. So we can get accurate percentage of, in blast in cases of CMLs, in which it is sometimes become a little difficult to give it on, Leishman or simple stain. So we do MPO for that. So,
all right. And one last question. What's your opinion about AI algorithms? Because a lot of automated analyzers have come which have image analysis as well. Are you using that in your lab for diagnosing leukemias?
We are not using it. We are still, not shifted to automated analyzers right now. We are doing it by own, but yes, few of the labs are using it and they have very good response in that. But we will be shifting it in future maybe, but we have not shifted it.
Perfect. Fine. I think if there are no more questions, any other things? Audience, any more questions? Otherwise.
No questions from audience.
Yeah, thank you all. It was a very informative session and brief and crisp as well. Thank you so much.
Thank you so much.
Thank
Thank
you,
you,
everyone.
Thank you, ma'am.
Thank you.
Thank you. Yeah.